Hello again, my name is Eric Keller with Interventional Initiative, and welcome to Module 4, where we're going to talk about some additional ways that we can augment consent conversations through compassionate communication. What is compassionate communication? It's communicating in ways that foster understanding, connection, and compassion, particularly when faced with challenging conversations, such as those we often have in healthcare. To start, it's really important to remain empathetic and curious. So just because you are an expert in a certain disease or treatment does not necessarily mean you know how it's affecting that specific patient. And the ultimate value of what we do is dependent upon how our interventions affect and are perceived by our patients. It's really helpful from the beginning to start these conversations by asking what's their baseline understanding of what's going on? What are they concerned about? And when you get to discussing treatment options, what do they value? By starting conversations like that with that baseline understanding, you can then adjust accordingly to really have better conversations from the beginning. So for example, do you need to first talk about cirrhosis and portal hypertension before you get to talking about tips? Or maybe they think that you're here to cut out their tumor rather than ablate or biopsy it. It's helpful to know that up front. You can also listen carefully to how they describe things when they're telling you their understanding to get a sense of what their baseline health literacy and numeracy is and adjust your descriptions and conversation accordingly. That way you don't speak over someone's head or come off condescending. Healthcare really is its own language, and we take that for granted because we're around it all the time. The only national survey of literacy and numeracy in the United States found that the average reading level is about 6th to 8th grade. Over a third of US adults have limited health literacy, and that number increases to 59% among those 65 and older. So many patients aren't going to understand words like bill or a catheter, ablate, or embolize, particularly when you introduce other barriers such as language barriers. Likewise, people tend to understand risks and benefits better if it's described as 1 in 10 people rather than 10%. So putting all that together, it's better to say 1 in 5 people will have some air leak out of their lung after a lung biopsy, rather than saying there's a 20% chance of pneumothorax. It's also helpful to use relatable comparisons and engaging visuals in these conversations, really help people understand your proposed treatment. So for example, you might describe a lysis catheter as a tiny soaker hose that busts up blood clots. You can also use our patient decision aids, that's what we made them for, which are standardized handouts with engaging graphics and balanced information on the risk benefits alternatives of common image guided procedures. Many practices do have their own home-baked informational handouts, but studies suggest they tend to be pretty variable in the information shared, with readability scores well above the average reading level. So we actually spent a lot of time and money with our nonprofit to develop better patient decision aids vetted by physicians across practice environments and patient-focused groups to make sure that it's really doing what we intend it to do. And we even tested them in clinical trials to show that they significantly improve patient understanding and satisfaction. By incorporating these small but impactful ways of approaching consent conversations and speaking to decision makers, you can substantially improve these critical conversations that we have with patients and families.